All right, guys, we're back. This week we are going to be covering geriatrics. I'm going to divide the lecture up into two parts. One is going to be just like pediatrics is going to be kind of the anatomical and physiologic differences, and then we'll get into the actual emergencies on the second portion of this lecture. So we're going to get started. Really, honestly, this should be kind of quick too, because just like pediatrics, where I'm just going to really just focus on the differences. And really with geriatrics, what you're going to hear a lot of is it doesn't work as good. It's not like it used to be. This function is starting to fail, or this is starting to decline. That's the stuff that you're going to hear. So a lot of this really is just touching on what's declining. I am going to hit some of the major neurological stuff when we get down to it, especially when we get down to dementia and stuff like that. I really want to cover that. I really want you to have a good understanding of those things when you hear it, because you are going to come into contact with a lot of these patients, geriatric patients. It's just the way it is. So people are living longer. We've got advanced medical practices, and it does extend longevity. So let's get it right to it. All right, so geriatrics are considered anything age 65 and older. It makes a little side note down here that basically, the 20s are your prime. And being in my 40s, I will definitely say I do not feel the same way I did when I was 20. I don't have the same gumption. So in just the 20 years of my slow, steady decline into geriatrichood, I have definitely noticed the difference. They are becoming a larger portion of the population. You can thank the baby boomers for that. And for those of you who don't know, that's the generation that would be my mother, who is currently in her 60s. Her parents had, or her parents' generation actually, had 4 and 5 kids. She is one of 5. They just had quite a bit of children. There was the beginning of the what was called the American Dream. White picket fence, 3-bedroom house, quarter-acre lots, that kind of stuff. 2-car garage. Mom stayed home. Kids played out in the street. That kind of stuff. Leave it to Beaver kind of stuff. So one of the things that we do want to talk about, and I do want to kind of touch on this, because when you run some of these geriatric patients, you'll get called out for them, and it will probably be family that calls. And they're saying that the mom's not acting right, or you'll get like a caregiver, or like maybe an in-home nurse, or even the nursing home. We'll talk about that stuff too here in a little bit. But really, what you got to really take in consideration, like some of these people only live on Social Security, and Social Security covers quite a bit, but not everything. And these people don't have a job. And now that they've retired, whatever retirement they gathered, aside from Social Security, if they were able to get a retirement, is now their fixed income. And now they had to base the fact that, say they did retire at 65. Well, people aren't dying in their 70s. They're living into their 80s and in their 90s. So now, if you plan on living to at least age 85, you retire at 65, that's 20 years of whatever income you managed to put back and save, or have a 401k. Now they have to live on this. So the part of the problem that you're going to run into is that you're going to run these people, and they're going to be concerned about the bill, and you're not going to be able to talk them down, because they'll be alert oriented times 4, and they're going to be worried about the cost of everything. Some of the patients are supposed to be taking medications, and you'll have and they can't afford to pay the copay on the medication, because it's just not part of their budgeted weekly expenditures. They plan for food, they plan for rent, or their wherever they're living. The utilities. If they own a home, they're probably looking to pay the taxes, and it may only be like $200-300 a year, but still, that's still a cost. So they may actually try to skip medications. I've seen that done before, or do the medication dose in half, and it's not therapeutic. It's not a therapeutic dose, and they're not reading their therapeutic index for the medication to work, and there they are. They're struggling, having a problem. So this is a real problem. Excuse me, Rona. A lot of seniors also don't want to live in assisted facilities. And once you get into EMS, especially if you start running 911, or you do a lot of general transport stuff, and you go to the nursing home quite a bit, you are going to find that you can't blame them. So a lot of these people live alone. Unlike Eastern cultures, where family is the cornerstone of survival, we here in the Western civilization preach independence. And when you live independently for 65 plus years and you're on your own, but your health is declining, and we're going to find out, we're going to talk about all the things that are in decline. It's very hard to go back to having a caregiver. Typically what happens is they either live by themselves and things happen. We always laugh at the life alert, but believe it or not, those have saved people before. I have run calls where people have activated the life alert, and thank goodness they had it. Otherwise, they would have been there for days, hours to days, and that's horrible. A lot of the primary care givers that are taking care of these geriatric folks are their kids. So you've got kids like in their 50s and becoming geriatrics themselves, and they're taking care of their 80, 90-year-old mom, and their 80 or 90-year-old mom or dad are still with it. They still got a lot of good mental function, and they're living a good quality of life. But it's hard. It's very difficult. So these are some of the things that you're going to run into. Kind of along the same lines what I said. All right, so let's move into, let's talk about like DNRs, advanced directives, end-of-life care, hospice, things of that nature. So basically, if you run a patient and they're alert and oriented times 3, the questions that I ask is, who's the president of the United States, whether you like him or not. You can ask, do you know where you are exactly? And as long as they give city, state, that's fine. And I ask them for the date. Now, keep in mind, some of these people may not know the date. So maybe ask about a upcoming holiday or a holiday that's just passed. Also, how many quarters does it take to make $1? That also helps. So that's how you kind of gauge whether they are alert and oriented times 3 or times 4. One of the things that I do want to stress here is DNR means do not resuscitate, in case you didn't know. It basically means in the event that they stop breathing and their heartbeat stops, you are not to resuscitate them. And usually people who have terminal illnesses like cancer or any type of terminal illness, usually it's cancer, they usually have the DNR in place because the cancer is so bad, it's so widespread, they can't fight it fast enough. It's growing faster than they can fight it, or they are done fighting it. I've seen that too. They're just done. They've been fighting it for years, and it keeps they go into remission, it comes back, and they're having to fight it, and there they are, and they just basically say, I'm done. I'm tired. I don't want to do this. I'm just going to not do the chemo, radiation, enjoy what time I have left, and not be sick. And even though I'll have this cancer, it'll eventually will make me sick, but during that time I won't have the chemo, radiation, sickness, and I'm going to do that. So one of the things I do want to stress is DNR, though, does not mean do not treat. So if you do have a patient in the back and they are wanting help, just because they have a DNR doesn't mean like, oh, well, you have a DNR, so we're not going to do anything for you. That's not what that means, okay? So I want to stress that because I've seen that happen, and it was very upsetting. There's a physician's order of life-sustaining treatment. I'm going to show you what that is. Here, I've got a form. In North Carolina, and I only know this because I work in North Carolina, it's called the MOST. It's called a medical order for life-sustaining or sustaining treatment, stuff like that. So they're called different things everywhere else. I don't know if this is what Georgia has. Usually it's just called advanced directives. They say, yes, I want to be intubated. Yes, I want CPR. Or I just want to be ventilated. No intubations, no medications given in the event that I'm struggling. But if I stop breathing, you can breathe for me. But if I go into cardiac arrest, just let me go. Don't do any CPR. Don't do any of your ACLS care. So that's stuff like that. Healthcare by proxy, that really means power of attorney. That's what we use now, at least in Georgia. That's what I'm very, very familiar with. And there are different types of power of attorney. You can have financial power of attorney. The one that we're worried about is the medical power of attorney. And basically, this is when this person is in sound mind and body. They go to a lawyer's office and they sign over their rights in the event that they are not alert and oriented times 3. If the patient's still alert and oriented times 3, that's where it becomes very difficult, because if you get on scene and you have a medical power of attorney, technically the rights are gone. So if say like the daughter or the son has the medical power of attorney and they say, yes, I want this person to go to the hospital, it puts you in a bind, because they're like, yeah, I know who the president is, I know where I am, I know exactly what date it is, 4/4 make a dollar, I can answer all of your questions appropriately, and I'm not going. That puts you in a bind. I've been in that situation before. And unfortunately, what happens is the medical power of attorney, what they say goes. So there you are. Then you're having to negotiate, and you got to keep a level head, be calm, be cool, and you kind of have to bargain and negotiate. Hospice service. Hospice service is for, like it says, the terminally ill, and terminally means they're dying. And really, what it is allows the patient, well, not you, but the patient to go home. They go home, and basically what it is usually like the caregiver, whoever's there. It could be a nurse. It could be, which is, they will be followed by a nurse, a hospice nurse. But it also gives like the family or the medical power of attorney the right to go ahead and give them like medications like morphine. Just to make them comfortable. They're going home. You make them comfortable. They spend their last days at home, not in a hospital. And they spend it with their family, and they try to be close, and the family, it also gives the family time to grieve. The problem with hospice, if the medical power of attorney says treat them, because you're gonna find this, man, they're dying, and the family is having a hard time with this, even though they went home on hospice care, they haven't accepted the fact that yes, this is what hospice it really is. They're going to die. They say, no, treat them, transport them, take them. And then the medical power of attorney, and here you are, you've got a very, very super sick person that is dying. You kind of have to do that. But once you do that, that terminates hospice care right then and there. And then they have to go back through the whole entire process, which usually hospice is pretty generous about. They're like, okay, it's cool, you transported them. Not supposed to do that, we'll keep you. But usually that'll terminate hospice care, and then technically they're supposed to start the process all over again. So that's something to consider. But again, medical power of attorney wins. Unless there's a DNR. DNR will supersede medical power of attorney. But the conundrum is, if they're sitting there crying, oh, dude, save them, and you're like, okay, they have a DNR, but you're the medical power of attorney. So then you have to work them. I mean, you get into where you really have to have a conversation with them. And obviously, when someone's in cardiac arrest, that's not the time to have a conversation. So it's dealing with end-of-life care, especially with geriatrics, is very sad, and it's very, very conflicting at times. So you're going to have to just do the best you can. Hopefully, I've kind of given you some information enough to help you get through that. That's the physician order of life-sustaining treatment. I think that's California's, if I remember, but they're like this. And I know for North Carolina, I couldn't find one for North Carolina, but usually this is supposed to be posted either at the door, near the patient, somewhere where it's green, I think, or yellow, bright yellow or bright orange or something like that. It's like this bright ugly color, or on the refrigerator. Usually they're supposed to be on the refrigerator, if I remember correctly, because that way everyone knows in the EMS profession in North Carolina to go look at the fridge and see if there's something there. It's kind of like a unspoken rule. I'm not really sure, but it's supposed to be in a common area where everybody knows to go look for it. All right, so you get on scene, and you're not dealing with any of that stuff. Let's say you're not dealing with DNR. You're dealing with a person of sound mind and body and their own entity. It says use open-ended questions, but let me just kind of warn you about open-ended questions. If you do use open-ended questions, so what kind of medical history you have? Remember, there's 65 plus years of medical history here. You're going to probably get the whole gambit. I usually like to start with closed-ended, which means yes or no. Open-ended allows them to tell the story. So I usually like to start with closed-ended. So, are you hurting anywhere? Okay. Is this new? Okay. So what's been going on with this? And that's how I segue in. Listen to them. It's like any patient. Listen to them. One thing I do want to advise you not to do: don't call them sweetheart. Don't call them dear. None of that. Go ahead and just talk to them like they're normal people. Yes, ma'am. Yes, sir. Of course. Yes. Treat them as you would anyone else. Obviously, we're going to not be judgmental. You're going to have to gain every patient's confidence. And one of the things, though, that will probably be really good is talk to the patient. And if you can see that you're just not getting where you need to get because there might be some altered mental status, and it might be just previous history. That might be just their neurological norm. Rely on the family member to get what's going on today. Why'd you call me a mess today? What's different today than any normal day, and stuff like that. So you may have to rely more on the family member. And again, just because they're family doesn't mean they're medical power of attorney. So again, there's a lot of that gray area that you're falling in. Okay, nursing homes. All right, so there are a lot of good nursing homes or skilled care facilities, or nursing skilled facilities. Sometimes, though, you'll get into a situation where you're going to get up there. And really what you want is a lot of the information. And sometimes it's very difficult because sometimes patients are found at shift change. Like they were seen at 5 o'clock, here it is 7 o'clock, and now something's changed. They weren't like this. And nursing home and skilled care facilities are very understaffed. So it's very difficult for them to keep eyes on a wing of 30 patients and there's only 2 or 3 people. And they've got to make rounds with medications. They make rounds, every several hours, giving patient meds out. And they've got what's called a med pass. They have to pass through the whole hall and give out their medicines. And then as soon as they finish the med pass, they may get a break for about 15, 20 minutes. And they have to start the med pass all over again and stuff like that. So you're going to be probably relying on these people to tell you what the neurological norm was versus what it is now. So you need to be listening to them. It's very frustrating sometimes because they get called out and they usually have to call the doctor and ask like, hey, what do you want to do? And the doctor like, oh, just send him down to the ER or just ship him out. Just send him down or send him over to the ER and see what happens. So that's very frustrating. Another frustrating thing is that they have been trying to get the patient better, maybe like some difficulty in breathing, and they've tried breathing treatments and they've got the oxygen on and they're getting sicker and sicker, and the doc says, okay, send them down. And it's usually at night. That's where it's the most frustrating because the doc does sleep and he's usually over the whole entire facility, or there's 1 or 2 doctors and they take turns and it's hard to get a hold of one, and when they finally get a hold of one, it's been maybe an hour or so and they're declining. So there's things of that will frustrate you, but don't get frustrated. Keep a level head and just keep on keeping on. If you are taking someone out of the nursing facility or a skilled care facility or an assisted living facility, get as much of the records as you can. You want all their medicines. You want all the things they've been seen for, any discharge papers that they've been seen recently at the ER, like the past several weeks. You want stuff like that. These nursing facilities are very, very, very susceptible, and it's like living in a college dorm, except you have people that are even more immunocompromised. So they're going to get sick a lot easier, and they will pass this stuff back and forth to each other. And it'll be MRSA, it could be, C. diff, stuff like that. I mean, it's just horrible stuff. C. diff, there we go, yeah. They're saying the many causes of death, we'll get into all that stuff. Their declining body cannot keep up with the spirit is usually what I say. They usually have a spirit, they're with it still, but regardless, their age, you can't outrun time. So their body is in decline, stuff like that, but we're going to talk about this stuff here, so I'm not going to go into it here. Oops, too far. Sorry. All right, those are some risk factors. I'll let you look at those. This basically says that just because they're older doesn't mean they're the stigmata of can't hear, have no clue what's going on, don't know what day it is, stuff like that. Actually, you'll find that a lot of the geriatric population are very with it, especially if they live independently, because it does take quite a bit of cognitive function to live on your own. We're going to kind of go on all this stuff, but one thing you have to know that basically the body temperature will decrease, all the stuff we're going to talk about. Here we go. Respiratory system. So the alveoli, they start becoming like enlarged. They start losing that elasticity. Even though they may not be COPD patient, they're still going to lose some of it. The receptor sites that measure O2 and CO2, those start to slow down and decline. So they start losing those receptors to be able to judge when they should breathe. Those receptors tell like, hey, we got too much CO2, let's breathe it off, and stuff like that. With the decrease in respirations, they're obviously going to build up more CO2, so they're not going to breathe it off, so they'll be maybe a little bit more acidotic. We'll talk about some of these other things. Increased likelihood of airway obstruction, so they have a hard time swallowing. We're going to talk about all this stuff. Let's get into it. Cardiovascular output, cardiac output, for the cardiovascular system winds up declining. They don't have the good stroke volume, lowers their ejection fraction. They're just not pumping as much blood as they used to because it's still a 65-plus-year-old heart. I mean, it's what it is. Blood vessels stiffen, so they wind up being extremely, extremely hypertensive because there's no flex or give in the arterial walls anymore. So it's a lot more difficult to overcome that pressure. That's why they start losing their ejection fraction, because the heart just can't overcome the pressure that's now exerted on it to pump blood systemically to the rest of the body. The conduction system, remember the SA node, AV node, bundle of His, bundle branches, Purkinje fibers, that starts losing its automaticity, and you have the conduction sites start becoming aged, and you start having dysrhythmias. It's very common. People sometimes go into AFib, irregular heartbeat. The atria are not really contracting, and then you have a whole myriad of problems with that. Atherosclerosis, buildup of plaque, that happens. That's normal. Everybody has that. You're going to build up plaque. And it's really just how your body processes plaque. It's not just the fact that you eat a lot of fatty foods. It also has to do with the fact that your body may not break it down. So they usually wind up taking a statin drug for that. So abdominal aortas are very, very common. And anybody, like anyone, if it ruptures, you're dead probably within 30 seconds or less. The nervous system, this is the big one. This is the big one. We're going to get right into it. Vision, obviously, is impaired. I promise you that my night vision is not like it used to be. Visual spatial acuity, like where you are in relative, like the steps. Old people miss steps all the time, trip, fall, and hit the steps. That's bad juju. Cataracts is basically when you start having cloudy vision over the lens of the eye. That's really bad. You'll see those, and it impairs their vision. I mean, imagine if you just had a fog in front of you constantly, and you couldn't see through it. That's always an issue. Macular degeneration, it actually winds up being the macula, which is the area of the eye that's close to the optic nerve. It starts just wearing down, so their vision starts just going. There's retinal detachment. That's like if they kind of bump their head, they can have retinal detachments. And it's basically they'll build up blood, like kind of like a stroke, like an aneurysm. It will build up behind it, and they'll have a blood pocket, and it'll put more pressure on the eye, and they just can't see can't see any better. Glaucoma is the aqueous fluid that's inside the actual eye itself builds up, and it can't cycle through like out of the tear ducts and stuff like that. So they start having a lot more pressure exerted on the inside of the globe of the eye, and it puts pressure on the optic nerve where they actually can't see because the optic nerve doesn't want to be pressed down on it. It just wants to do its job, and it can't. Hearing. Of course, they're going to start losing their hearing. They start having hearing aids. But let me caution you about hearing. Just because they can't hear doesn't mean that you have to change your tone or the speed in which you speak to them. You do not have to talk like this to them. You just need to raise your voice and talk to them in a normal manner. That's all you've got to do. They talk about presbycusis. It's just exposure to sound over time, loud sounds. So like all you kids blasting and thumping your stereo systems, pretty soon that'll come back to haunt you. Permanent damage. Taste. They can't taste what it tastes as good as they used to. So food just kind of loses its flavor, but they can't really tell the difference. So they just kind of eat. They just eat. They don't notice it because remember, all of these things are gradually over time, a long time. So they lose these things and they just have learned to adapt to them. And now here they are. It's not an overnight change. So keep that in mind too. They lose their sense of touch. They can't touch. So like they can burn themselves or they can cut themselves and not know it. That's always a thing. Can't smell as well. And we're going to talk about, I believe, dementia. All right. If you weren't paying attention and just had this playing in the background, you need to pay attention now. Dementia is a big global umbrella, if you will, for cognitive disorders in the geriatric patients. And dementia is just really just they're kind of losing their attention span. They don't think as clearly as they used to. They're kind of disoriented. Okay, and it's gradual. It is gradual. That's dementia, okay? there is something called delirium. Delirium is something that's very acute, very, very sudden, probably over hours. It's one thing that they're like, okay, they got a little bit of dementia, and all of a sudden they're just acting weird, odd, not the same. This is not the same person like that woke up this morning, or this is not the same person that went to bed last night. You do a stroke test, and they're able to pass your stroke test, so it may not be a stroke. You check the sugar, it's not the sugar. That's delirium. Typically, and I know I'm going to jump the gun, but typically if you have some sort of like acute delirium in a patient, it's usually going to be like their blood sugar. It's dropped, or it might be too high, one of the two. Or it could be a UTI. UTIs are bad in the geriatric population. Obviously more so in women than men, but men still get them. So with that being said, if you have some acute delirium, maybe a little mild fever, they don't even have to have a fever, because we'll talk about why they won't have fevers here in a little bit. So if you have some sort of acute delirium, like they're like, yeah, they've got dementia, but this is just not them. This is like not like usually the family member will tell you this is not them. This is something way, way different. Usually that's going to be a delirium. And usually you want to kind of consider some of the things I just said, like a UTI, the sugar, check for stroke symptoms, stuff like that. But usually that's what you're looking at with like a UTI. Alzheimer's. Alzheimer's is a big bad dog. Alzheimer's is just not the fact that they're just not as sharp as they used to be. Alzheimer's is literally the death of the neurons. The neurons are dying. They're being destroyed. I put a picture in there so you can see the Alzheimer brain versus a normal brain. It does begin gradually, but what's happening now is you will have people that will lose memories. They will absolutely lose memories. They will lose thought. It destroys the brainstem as well. Like they will literally just stop breathing. That's usually what kills Alzheimer's patients, is the fact that it hits the respiratory center or the cardiovascular center in the brainstem, and it just destroys it. And once that stuff's gone, you can't get it back. The bad thing about Alzheimer's is the only way to really diagnose it clinically, like officially and clinically, is through autopsy. Obviously, or to actually view the brain. You're obviously not going to take a geriatric patient and open their skull and look at their brain. But they sometimes do it post-mortem when they've died. If they'll do an autopsy on them and they'll find it. So that's the true diagnosis. But typically Alzheimer's is very... It's not like they're not as sharp as they used to be. They will lose memories. They won't know who people are. And they won't know who they are. They won't know where they are. And it's just... It's debilitating. And especially more so for the family than the actual patient. You obviously feel for the patient, but for the family, because this person used to be able to know their name, knew who they were, and memories are gone. They're watching their loved one not even know who they are anymore, and that's very, very crippling. Parkinson's disease. So this doesn't have to be just in the geriatric patient, but obviously the patients are going to probably be older. There's something called dopamine, and remember back to our neuro, we talked about the dendrite and the neuron. The dendrite's the long stem that goes out to all the next nerve cell, the next neuron. And remember, they don't technically really touch physically. There's that synaptic cleft, and they use neurotransmitters to go across. Well, dopamine is the one they start losing. They actually start losing their dopamine neurotransmitter. And what it does is it starts having where they can't do motor function accurately. So that's why there's the shaking, and that's why they lose motor function and control, and it winds up debilitating them, and it starts affecting their respiratory muscles, and it's harder and harder to breathe, and it is a very crippling disease. So it's very important you understand that. That's what Parkinson's disease is. It's the loss of motor function, and it will wind up being that they will stop being able to control their breathing. So I just wanted you to understand what that is. One of the things that a lot of seniors and geriatric patients are faced with is depression and suicide. I want you to just think for a minute. I know a lot of you guys are young, in your 20s, early 30s. Imagine one day you could not do the things that you used to be able to do. I know some of you guys have families, some of you have children. Imagine your children are gone, they're grown, they're living their own life. And there you are, and then let's say you have friends. Obviously, you have friends. And your close friends are starting to die. And you're watching the world that you used to be in and know is just crumbling apart. Depression and suicide is very horrible. I have ran a geriatric suicide, and it was just so disheartening. I mean, I don't like the war story, but I'm going to go to it. She basically dressed herself up in her best nightgown. She got herself in the bed. She wrote a note to her family saying that didn't want to be a burden to her family anymore. She felt like she was burdening them. And then she took I believe it was a 22 revolver, and she put it to her temple and she pulled the trigger. And it was so surreal because obviously there was no exit wound. And so there's an entrance wound, and it was obvious death. But she was tucked in the bed nice and neatly in her beautiful pajamas. The bed and everything was immaculate. The house was clean, and she killed herself because she felt she was a burden on her family. That's also a thing that it's horrible. Like, aging is horrible, especially when you don't have a support system. Musculoskeletal system. You can't lift as much as you used to. Muscles are kind of degenerating. Arthritis is a big thing. Arthritis, if you remember back, is an autoimmune disease. Your body is starting to attack the joints in the hands and the knees and the elbows, and everything hurts. It hurts to walk. It hurts to lift. You can't. You're like, my God, I just want to pick up a glass of water and drink it, or a soda and drink it, and I can't. And I'm in so much pain and agony. And that's another reason why people will, geriatric population will kill themselves, is when they find out they have a terminal illness, or they're living in such debilitating pain that they just can't take it anymore, and they see no other way out. Kyphosis is the thing. If you've ever seen a hunchback person, I've seen tons of hunchback people. Their spine just starts degenerating down, and this is called kyphosis. It is the arching of the spine. Literally, it will make a 90-degree. Look at that. If you look at it, it starts here, up, nope, all the way over and out. So that's what kyphosis is. Osteoporosis. Basically, that's the bone does not regenerate as good as it used to, so it starts leaving porous holes in the bone. Trauma is a horrible thing. Like we just said, they can't move and bend and walk like they used to, and then they take a stumble and fall, and then you have broken hip, broken arms. It is so painfully crushing to watch a senior that it was just trying to walk, and they got tripped up over the rug, or they got tripped over their own feet, or they got tripped over they love their pets, and they're trying to feed their 12 cats or whatever, and they get tripped up over one, and they fall, and they get hurt really bad. Osteoarthritis destroys the cartilage in the joints, and that again, it's very debilitating. Gastrointestinal system. So they don't absorb as well. Remember, they're losing their taste and smell, so they may not eat stuff that is maybe it's out of date, and they shouldn't be eating it. The stomach is not breaking down or using as much acid as it used to. Their bowels start slowing down a little bit, and they don't absorb the nutrients like they used to. So now they're eating okay, and they're doing all right. That's why they try to say to drink the Ensure. I know that's maybe kind of funny, but like, it's filled with vitamins and nutrients. So like, you're trying to overload the body with the excess, because what they don't use, they'll just go ahead and defecate. So what they do is they just try to give them a lot of extra vitamins and nutrients, and hope that the body will absorb it. You put a lot of it in there, it's going to absorb it at some point. But if you only put a little in there, it absorbs some, but maybe not all. So the idea is to flood the system. They can't break down alcohol and drugs as much. One thing I do want to caution you is when we start getting into our advanced, weight-based dosing is very important. When you give geriatric patients medications, you may not want to give them the full adult dose. You may want to consider going ahead and actually just using maybe half the dose, and if that works or it doesn't work as well, give the remainder, because drugs will affect them severely. You can literally overdose them on some things that you normally wouldn't overdose a normal adult, maybe even the same weight. So you got to be real careful when you're giving drugs to the geriatric population. Dehydration, they're kind of like kids. If they wind up getting sick and they wind up having diarrhea real bad, they'll get dehydrated. Kidneys, the kidneys start losing their function. That's really from nephron loss. Remember, we talked about the nephron in the kidney, and that's the big bad dog of filtering. And what winds up happening is they can't filter as well, so they'll actually retain some of the electrolytes that they don't want. One of them being potassium. Potassium you don't want a lot of potassium. You want your potassium to be just right, because it will affect your heart. And they'll start having dysrhythmias and heart problems and stuff like that. So you can have an electrolyte imbalance very, very quickly. Hyperkalemia. Yes, that's excess of calcium. Adults are just kind of like kids do. They start becoming incontinent. They can't control their bowels as well. The musculature that they use to have the bowel control they're starting to lose that. They'll start losing their sympathetic and parasympathetic tone. So they wind up having to wet themselves. So they start using incontinence products like Depends or adult diapers. And if they do urinate, that stuff's kind of acidic. And if it touches the skin on them for too long, start causing rashes, just like kids. And so start breaking down the skin. And we'll talk about here in a little bit. The skin itself is thinner, and it'll start wearing it down and breaking it down much faster than it would in a baby. So there you are with maybe like decubitus ulcers. We'll talk about that here in a minute. Hyper and hypoglycemia is very common for the endocrine system in the geriatric patients. So always check their sugar if you can. One thing I do want to caution you, though, if you go to start an IV or you're going to go start or do a blood glucose check, you want to be very careful if they're on blood thinners. That means that they are thinning their blood because there are bleeding risk when this happens. So sometimes they may fall and they want some help up. They bump their head. They got a big put knot, and you're like, hey, look, you're on blood thinners, man. You need to go to the hospital and get checked out. I mean, you bumped your head. Yeah, you're fine right now, but you might have a slow, insidious bleed in the head, and you might wind up with a head injury, and you need to get checked out. And that's hard to tell them too, because like, nah, I'm fine. I just want help up. I fell. It's okay. I do this all the time. And you're like, dang, man. Thyroid abnormalities, the immune system, it is not as strong as you get older. So they're more susceptible to toxins, pathogens. They don't combat or build up an immune response as quick as they used to. They sometimes don't even have a fever because the body just doesn't use fever anymore because they're not mounting an attack. So part of what you're doing when you have a pathogen is you'll run a fever because, again, pathogens don't like hot. So your body says, well, I'll make it hot where you can't stand it, and I'll kill you that way. And what winds up happening is that they won't run a fever, and they might be septic. So you may have sepsis and not even know it just because they're not running a fever. So be wary of that. We talked about the skin. It becomes thinner. Nothing is more sad to see a skin tear. I don't know if you've ever seen a skin tear, but it basically is just like a flap of skin has been pushed and shoved off to the side, and they're bleeding from that. That's really sad to see. And they'll usually get them when they fall. Or they'll just brush up against a corner of something and it'll rip their skin. It's horrible. We did talk about decubitus ulcers, especially in the nursing home facilities. You want to watch out for these. I've seen patients with horrible decubitus ulcers. The thin is now skin. The skin is thin. The skin is now thinner, and the bone pressing against it, if they've been laying on that for too long, it will literally start to break down their skin. And they'll start having stuff like bruising and ulcerations. I didn't put one in there. Sorry, guys. But they'll start having it. And there's different levels of decubitus ulcers. But we're not going to get into that. But just know that they exist. Talked about infection, toxicology. We already kind of talked about the fact that the kidneys undergo changes so they can't get rid of toxins and process toxins. One thing, big one, big bad dog, polypharmacy, meaning lots of drugs. They might take multiple medications. Now, they may have good insurance. They may have done very well in life, and they've got great insurance and supplemental insurance and life insurance and all sorts of good stuff. So they go and see all these different specialists, but none of them talk. So they're seeing all these specialty doctors, and they're getting blood pressure medicine. Well, they might get metoprolol and low pressor. Well, that's the same medication. And one doctor's trying to do hypertension, and the other doctor is trying to treat like a dysrhythmia, and they don't know. So, and there are some that are very stubborn that don't take any of their medications. There are some that will literally plan it out and take their medications to a T. So there's that. So you need to be wary of that. But again, they're going to be taking multiple hosts of medications. Talk about the scene size up. Some of the things that you want to, or your patient assessment. You want to make sure that the scene is safe, obviously. Nature of illness might be harder to figure out and determine. So, depending on what's going on. So, again, hopefully you've got good bystanders there. You don't want to make assumptions of the level of consciousness. Again, rely on your family members. You want to probably intervene with oxygen a little bit quicker and talk about their airway. One of the things that could be an airway obstruction is the fact that they may have dentures or implants. If you're going to be dealing with that patient, and they've got them, and they're like, hey, let me have my teeth. Like, nah, listen, we're not going to a beauty pageant. It's good. I think you look great without them. Leave them out. In the event that that becomes a problem where you have to deal with their airway or manage their airway, and then they have these dentures and implants in, and then you're having to go ahead and remove them or deal with that. So I usually tell them leave them out. Yes, look for all those things. Obviously, airway, breathing problems, shock, bleeding, uncontrolled bleeding. Again, some of these patients take blood thinners, so it may be harder to control bleeding, and you may have to take them to the hospital just for that fact. They may need to have some help with coagulation. There is a class called GEMS. We're not doing GEMS right now, but it's a good class, and it is all about just geriatric assessment and what to do with geriatric patients. History taking, it might be harder to do history taking because you got to consider the source. That's why they said start with open-ended questions. I usually like to start with closed-ended, and then go to open-ended for once you kind of pinpointed what you're looking for. There are some questions to ask. It's kind of the same thing that you're going to ask everyone else. So, trouble sleeping, that's kind of a good one to ask. Remember, one of the things that you do want to ask is like, hey, have you been dizzy? Have you been falling a lot? Have you been falling more often than normal? That might be an indication that there's something going on neurologically. Make sure that they are pooping and peeing okay. And that if they do have incontinence products, are they getting help being changed? Or are they able or capable of changing themselves? Difficulty urinating. That's usually a good question to ask. Are you having difficulty peeing or pooping? Check the medications. Check the fill date, because sometimes they may forget that they've not taken their medications and will take double doses or triple doses of their medication. I've seen that before. I'll let you read those questions. Secondary assessments. Keep them warm. That's one thing I do want to stress and can't stress enough. Remember, the skin is thinner. So therefore, you need to go ahead and keep them warm. Assess their cap refill. Judge their skin. Skin will tell you a lot. SpO2, see how they're oxygenating. And always, always, always do a great reassessment. Make sure that the things that you're doing, are they working? Are they comfortable? Is the pain getting worse? Reassess their vitals. Make sure that they're trending okay. And that's all I've got for you guys right now. I will get the second one recorded hopefully within the next day or so and get it up. We'll see you guys then.